So, good afternoon, everyone. Wanted to take a few minutes to welcome everybody. My name is Linda Wyatt. I'm a healthcare senior manager here with Myers and Stauffer, and we're a national accounting and compliance firm supporting government-sponsored healthcare programs. And I wanted to introduce my colleague, Bobby Courtney, Managing Director here at Myers and Stauffer, who is assisting me today with today's session. We are here today on behalf of the Oregon Prescription Drug Affordability Board. Bear with me just a sec. Sorry. And I'm sorry. Let me regroup here for a minute. Anyway, we're here today on behalf of the Oregon Prescription Drug Affordability Board, which we also refer to as the PDAB or the board. And the purpose is to solicit some constituent feedback related to the use of upper payment limits or UPLs to improve drug affordability and to gather any recommendations you have on improving drug affordability for Oregonians. I do want to let you know we will be recording these sessions to ensure that we capture the feedback correctly. If you wish to speak and are uncomfortable with having a specific comment recorded, we do want you to let us know and we will temporarily stop the recording. All right, so a few other introductions. Joining us from the PDAB board, we also have Shelley Bailey, who is the board chair, and from the PDAB staff, we have Steve Koyman and Courtney Whitlock. Steve or Courtney, did anybody else join that I missed? All right.
Not that I can see.
Yeah,
okay.
We're good.
Great, thank you. All right, and then finally, I would like to introduce Jane Horvath. I believe she's joined of Horvath Health Policy, who is also supporting the board with their work and has provided some of the information on slides that we will be looking at in just a minute. So before we get started with today's session, first of all, we do want to say thank you for attending. Your time is incredibly valuable, and we appreciate your willingness to share your perspectives on this important topic. So to get started, we're going to kind of try to level set on today's topic, and we have a brief series of prepared slides that we want to review before we get into the discussion. And they should take about 15 minutes, and we ask that you hold any questions or comments until we've completed the presentation. And then once we've completed the slide deck, we also have a series of questions designed to solicit your input and generate dialogue among the group. During that time, we can't answer any specific questions related to the methodology or affordability evaluations, but we do have a mechanism for you to submit those directly to the PDAB for consideration. All right. So when we get to that point in the session, what we will ask you to do is introduce yourselves and speak clearly so that we can accurately capture your feedback in our notes. In addition, we ask that you please mute yourself when you're not speaking. You can use the raise hand function to be recognized to speak, and our logistics coordinator or one of the facilitators will assist with that. And lastly, we do recognize this is a very complex topic and one that will likely generate considerable feedback among stakeholders. And so for this reason, we are hosting a second meeting to continue our discussion and allow everyone an opportunity to share their perspectives. So with that said, let's get right in. So by way of background, the Prescription Drug Affordability Board, or PDAB, was established within the Department of Consumer and Business Services and is committed to protecting residents of Oregon, state and local governments, commercial and employer health plans, healthcare providers, pharmacies licensed in Oregon, and other constituent groups within the healthcare system from the high cost of prescription drugs. The board was established by the legislature under Senate Bill 844 in 2021 and then later codified into the Oregon Revised Statutes, Section 646A.693. And again, our goal with these sessions is to get your perspectives on the use of UPLs or upper payment limits to improve drug affordability and also to gather any recommendations you have on improving drug affordability for Oregonians. And these sessions will inform the board's work on developing a plan for establishing UPLs as required under Senate Bill 192. So through the authority that was granted by the Oregon legislature, the board is tasked with establishing a subset of drugs to review for affordability challenges within healthcare systems or with high out-of-pocket costs for patients in Oregon. And so the board is currently reviewing the drugs listed on this site and encourages you to review the website periodically for changes to the schedule or the drugs that are under review. And I will note that there was a board meeting yesterday, so I would encourage you to review their website for any changes that may come about as a result of that board meeting. So for purposes of providing some additional context, several other states have also established PDABs, and there are 3 that also have full authority to establish UPLs. Those are Colorado, Minnesota, and Washington. And certainly within the other states, Maryland, Maine, New Hampshire, Massachusetts, and New York have taken a little bit different approach to reviewing affordability and potentially setting upper payment limits. Colorado really appears to be the furthest along in this process, and they have actually initiated the rulemaking process to establish an upper payment limit on Enbrel. And if you're interested in knowing more about that or seeing how Colorado is approaching this process, the draft meeting minutes from February are out on their website, and I would encourage you to take a look at them if that's of interest to you. So in the 2022 report to the Oregon legislature, the board describes their concept. Ooh, sorry about that. The board describes their concept for a UPL in Oregon, and specifically this would establish a maximum amount that could be paid for a prescription drug. It would be a concept that's similar to federal upper limits, NADAC or MAC prices that are currently established and used in prescription drug reimbursement today. And it is not intended to set a list price, nor is it intended to impact the Medicaid best price calculation. So I know everyone in attendance here is pretty familiar with the complexities of the pharmaceutical supply chain, but for purposes of level setting and ensuring that everybody in our constituent group meetings comes from the same understanding, we put these slides together to illustrate the basic process for how retail and health system or physician administered drugs with their associated systems of payments, rebates, and product flow through the supply chain. And we'll actually come back to this concept in just a minute. So potential UPL principles. This slide is actually adapted from work that was conducted by Jane Horvath from Horvath Health Policy. And in principle, UPL should improve market function for prescription drugs with the UPL achieving one or more of the listed outcomes, such as improved access or reduced costs within the system. And these are concepts that we will talk more about in some of the questions that we will be discussing through our focus group conversations this afternoon and at our next meeting. And in returning to our supply chain diagram, what we're really trying to describe here is a situation in which the UPL is implemented here at the top of the supply chain flow. Or for another way of looking at it, we offer this as kind of a conceptual representation of a potential UPL model. And again, this is material adapted from work conducted by Jane Horvath and provides a little bit different view of the concept presented on the previous slide. Really, this is intended to illustrate the progression of the UPL through the various parts of the pharmaceutical supply chain. And as a reminder, of course, we were talking about a UPL sitting here between the manufacturer and the wholesaler, with kind of the purpose being that the model leverages some of the rebates and discounts perhaps that are in the system, with the manufacturer agreeing to sell the drugs to be used in Oregon to a wholesaler at the UPL. the wholesaler buying a UPL perhaps minus a discount, selling to pharmacies and hospitals, again, potentially at UPL minus a discount. Then any bills or claims are submitted to the insurers, the PBMs, or the patients based on the UPL, perhaps again with a discount. The patient pays their deductible and coinsurance based upon a UPL. And then the insurer, the PBM, is intended to reimburse the pharmacy at UPL less any discounts. And the insurer billed for the PBM or billed by the PBM for prescription claims that are billed at an amount reimbursed to the pharmacy, with the maximum in these situations being the UPL. And as we've mentioned, the UPL is intended to replace pricing indicators that are currently used now, WAC, AWP, AAC, those sorts of things, becomes the metric for the financial transactions for these particular products. So in January of 2024, there was a decrease in the WAC cost of several prescription drugs. And so we felt that this industry event might serve as a guide to show how a UPL might work in the marketplace or might function similarly in the marketplace. And as I'm sure most everyone is aware, there were changes in the federal Medicaid drug rebate program rules, and this had an impact on the rebate rates that would be paid by manufacturers to the Medicaid program, and in some cases quite significantly. And in response, the manufacturers for certain highly rebated drugs in the Medicaid space implemented reductions in the WAC for these drugs. Examples of things where we saw this included Advair Discus and some insulins. So we would encourage you to keep this concept in mind as we move into interactive session, believing that it could serve as an analogy for how UPL might similarly impact the supply chain. And so finally, as we move into the group discussion, we do want to say that we know that many of you participated in the survey that was provided in advance of these sessions, and we really appreciate those responses. And so we are going to explore some of those same questions now in our session. Appreciate your feedback and comments. And we will try to dive a little more deeply in some cases into some of the responses that we received. As a reminder, if we would ask that you do remain on mute unless you're commenting. And when you would like to speak, please use the raise hand and state your name and organization for us when you're making the comments. And of course, we've also provided the information if you'd like to provide some written feedback to us or to or participate in the public comment process through the board. You can use the mechanisms that are listed on the screen. So we will open it up now and start the conversation and comment session.
Great. Thanks, Linda. Just one thing to say to piggyback on Linda's comments about the survey, that does remain open. So if you didn't have a chance to respond, you have time. We'd love to hear your feedback. So please feel free to do that. And if you don't have the link or don't have it any longer, please just let us know through that mslc.com email, and we can certainly get that back out to you. So I guess just to jump right in here in terms of our group discussion, we've kind of organized the questions, for our discussion today and during the next session around some kind of key areas. And we'll start with just broadly the impact of drug affordability. And what we want to do before we kind of get too far in the weeds here is really kind of look to you to, to tell us, how you think of affordability when you think about drug costs today from the perspective of your organization. So, looking at how that, how you might define that, what challenges maybe unaffordable drugs present to your organization. So again, if someone wants to jump in and raise hands or just come off mute and respond, we'd love to hear your feedback. And again, that could mean, to your organization specifically, could be to, key stakeholders. Really just want to sort of, as we're talking with various groups, really sort of understand the specific perspectives of each individual kind of group. So from the perspective of your organization specifically, yeah, Justin, feel free to jump right in.
I mean, I think there's a couple of different levels from an affordability perspective in an insured pool and population of patients. As I look through kind of the outline of the Oregon PDAB, I understand this to be targeted at individual transactions that do carry a significant cost to our members, the patients. And those are important, right? There's a lot of question around affordability of drug and how a member affords that over time. But from an insurance perspective, we also have to look at the impact of trend utilization, price increases, low utilized, high cost products, right? And a lot of this gets worked into as you put together premium calculations and actuary review. So that price, high cost per claim, is certainly part of the premiums of the groups that members are a part of. And that construct, right, the actuarial construct is about pooling dollars and pooling expense across risk of a population. So, as I'm learning a little bit more about, the Oregon PDAB's approach, I hear an awful lot about those individual cases and claims for members that are oftentimes unaffordable, right, and very difficult for the member. But the healthcare industry, particularly with pharmaceutical pricing and really all trend and utilization, is much more complicated than trying to curb unit costs for members, because we're dealing with large populations, pooled populations, and there's cost sharing between employer groups, between state and government agencies and members. So it's a very complicated space, which we know, right? We saw your flow chart is a simplified version of all the financial transactions that actually happen. But that when you ask about affordability, I think as a health insurer, we have to think about all of those aspects. And there's lots of conversations in the industry around rebates and price and unit cost, and how that impacts both affordability of a plan that a member's a part of, plus the individual patient level experience. It's a very complicated environment, or some would argue probably too complicated. But what I'm seeing so far is a lot of intention about bringing down a select list of drug price points for members, and I think there's some nobleness in that effort. But as the pharmacist in me, when I see 2 GLP-1s on a list and there's 12 on the market, my head starts to go, is what happens to the others? Because we look at classes of drugs and market baskets of drugs and try to make the best net cost decision for our insured population. So that's where my head goes around affordability. And then maybe my final comments is, and I think people know this, but drug pricing and some of the examples that y'all provided for insulin and inhalers and things, drug pricing is largely set at a national level. And there's a tremendous amount of interstate commerce that's going on with wholesaler contracts, pharmacy contracts, PBM contracts. And I saw your note that this is targeted at drugs dispensed in Oregon. But take Portland, for example, there's a lot of members that live in the city of Portland that get healthcare received across the river and the border and in other states. So those are the questions that come to my mind. Not all for answering on today's purpose in today's meeting, but those are the things that make me kind of scratch my head a little bit and go, I get what we're doing in a particular state, but healthcare is very much crosses state lines, right?
Oh, that's great. And I think that's exactly what we're looking for, is that kind of specific concerns or just potential struggles with implementing a UPL, specific to your organization that we'd love to hear about. So, I mean, any other comments from the group? Specifically regarding sort of how you see affordability, just broadly? Got a quiet group this afternoon. Must be lunchtime in Oregon. I guess we can jump to our next question. And this is, I guess, maybe sort of restating a little bit what we've just been talking about, but in responding to the survey, a number of respondents indicated that they were somewhat or very concerned about the impact of affordability broadly on the organization. Could you tell us a little bit more about what those specific impacts might be? Justin gave some examples specific to his organization, but again, I think we'd like to hear as many voices as possible here.
My name is Elizabeth Jackson, and I'd like to add to the discussion more related to what Justin just said. Is we also have to take a look at the trend of the utilization of these drugs. And when you look at the drug affordability, we also have to take into account, like Justin was saying, the drug classes. We just cannot just look at one particular drug. We need to look at the whole picture. And the pharmacist in me sees you're looking at therapeutic outcomes. So if you look at just one of the drugs, then I think you'll be missing the picture. So that's what comes to mind.
When you say considering therapeutic outcomes, do you mean that in the sense of how the UPL model is constructed, or do you mean that in the sense of just thinking about the drugs in that class and sort of making the right kind of selections or for the
Yeah, that's what I mean when you're selecting the right drug for the right patient in that sense.
Right, and it's Justin again. I'll maybe just add on to what Elizabeth said. Another parallel consideration here is some of the work CMS has done in Medicare. I think it's also important, right? They've selected their top 10 drugs, albeit for a different purpose of negotiating directly with manufacturers, right? Which is different in Medicare. But, again, the practicality of me as a pharmacist in the industry, some of the products that they picked, they selected one line of insulin. Well, there's two major manufacturers out there. And in health plans and PBMs and health employer benefits, I guess maybe this is part of what's compounded us to the situation of prices continuing to go up. But we've tried to make the best decision, like, is there a preferred line of insulin products? And, kind of glancing, there's a couple of products, again, on the list that you showed that doesn't, it's not taking into consideration the full market basket of drugs, right? Drug like Ozempic and Trulicity may have longer track record of utilization. But, to Elizabeth's point, there's arguably some superior clinical value on other drugs like Mounjaro and others that maybe don't have the claims experience that have caught people's attention, but that's ultimately where the market is shifting, right? We're seeing more and more utilization of those. So it's a challenge when you're having to select drugs, and I don't envy people that have to make the decision on where to start. But the market's ever evolving, and particularly in that category of drugs, GLP-1s, which are getting attention everywhere today, there's a lot of new products that are coming that actually have some very different and unique pharmacological attributes that could take over utilization of Ozempic and Trulicity very fast, right? Because they have better outcomes, they have better tolerability, they have better dosing regimens. So, you know, we from a payer perspective are always looking at pipeline and products that come out and trying to do our best to predict and project not only where past utilization's been, but where future utilization's going to be. And it's an ever moving target, right?
Mhm.
I know we've got a pretty large group on today. Any other comments on the particular just affordability broadly and what that means to your organization? The impact of those affordability issues. Go ahead, please.
Oh, this is just Chair Bailey speaking. I just also wanted to remind everyone that if it's helpful to support our dialogue, anyone that does want to say things that they don't want recorded, they can certainly make a comment, but beforehand mention that they don't want to be recorded. So I just wanted to make sure to remind everyone of that today.
All right, well, do we want to move on to the kind of next topic area, kind of looking at the kind of desired state, I guess, if we've talked about kind of level setting around, what affordability means, kind of want to talk a little bit about, what outcomes from the perspective of your organizations, what outcomes would be necessary for you to consider, a UPL program to be successful. And like I said, from the perspective of your organization or your specific stakeholders, obviously, members in this case, again, what would you consider sort of that, demonstration, what would be demonstrative of success from your perspective? Or asked another way, what might an ideal, UPL program look like in the state? That could be specific to the methodology that the board establishes to set that UPL. Justin, go ahead.
It's Justin again. So I have a question, maybe. I think about stakeholders involved here, right? You showed the supply chain. Can you help us understand what the drug affiliate or the PDAB's statutory regulatory authority is over those various supply chain elements? Like, I understand, right, the premise here is to assign a UPL that the manufacturer can charge said wholesaler. Is there going to be regulatory requirements on wholesalers to then have a reasonable price that they sell to a provider or a pharmacy, and that we would have to reset like complex healthcare contracts, right? Because the way contracting is done on pharmaceuticals today is generally based on some percentage of WAC or some percentage of AWP. What I'm understanding to come to light here is there be select drugs that have a UPL in Oregon, but does PDAB have that regulatory authority to enforce at each level? And are you also looking to enforce what type of margin and markup is reasonable? And what about large organizations versus small that have purchasing power? Like those again, the stakeholder piece, and I understand the health plan side, and we have a good lens into all of it, but there's potentially lots of parties that are going to have to reset contract terms to be able to get this all the way to the end user, which is the patient. Is that within the rulemaking authority of PDAB to put those type of controls and constraints on each of the supply chain entities?
So we're certainly not in a position to sort of answer questions on behalf of the board, and I don't necessarily want to put the board members on the spot. But if they do want to respond, certainly want to give them an opportunity. But that is something, Justin, that we've heard in speaking with other groups, and I think I would kind of ask, kind of flip the question a little bit to say, what would I mean, you've pointed out that, some type of regulatory authority or ability to, push those policies towards specific stakeholders might be necessary or would be a necessary component of this from your perspective. You're on mute, Justin, if you were talking, sorry.
I'm sorry, I lost connection there for a second. Can you repeat that?
Yeah, no, I was sort of giving the board members an opportunity if they felt it was appropriate to respond to a specific question. I mean, in terms of our role, soliciting the feedback, we're not at liberty to really answer questions on their behalf. But what it sounds like you're asking is, or suggesting rather, is that in order for a UPL to be implemented successfully, it would really require some regulatory authority, perhaps. To hold certain stakeholders accountable to certain actions.
I think so. Some clarity, right? Because this is going to be a select number of drugs in a very complicated contractual world that's very isolated to dispensing in Oregon. I gave a couple of examples, right, where interstate commerce comes into place. I think it'll be important to note, and then it gets a little bit sensitive too, is if you start setting, suitable pricing ranges and price points, we're sort of wondering, like, does this mean that we're putting a UPL essentially at each level of the purchasing process? So it's going to be important to understand that, because at the end of the day, we hold contracts as a health plan and a payer with providers. And there's a supply chain that's built around it, and we're going to need to know how to work with those entities to enforce the intent of the board, right, within reason. And it's going to vary from a largely national footprint of drug pricing. So it's going to be really important to understand what the controls and requirements are for each of those parties. And if somebody steps out of line, where's the correction, right? And where's the adjustment that needs to happen? So I understand the intent. I think the logistics as an operations and a contracting person, or kind of where my head goes, is like, how do you get this done, right? That's always the $1 million question when we have a new specific type of requirement on a small slice of healthcare, because this is a pretty small slice of healthcare.
Mm-hmm.
Well, and not to jump too far ahead, but what you're touching on, kind of the administrative burden of implementing from just even the contract perspective. Do you want to speak a little more to that? What does your timeline typically look like when renegotiating or revising contracts?
I can't speak openly on that under recording, because I think it's complicated, right? There's different timelines for pharmacy and medical, and depending upon how those contracts are formed. And in the pharmacy chain, pharmacy provider world, there's intermediary entities also that smaller independent retail pharmacies use. That's a difficult question. I think it's cyclical, and those cycles vary by provider and by health plan, but I couldn't give you a specific off the cuff.
Yeah, that's helpful. But I think to your larger point, it sounds, and correct me if I'm wrong, I think to your larger point, it's just the administrative complexity associated with all of that. It sounds like that's something that you would argue really needs to be sort of ironed out, understood at the outset, so that it can accommodate again, kind of the administrative aspects of your line of business. Any
So-
other? Go ahead, Linda.
Yeah, no, I was going to say we've heard a couple of times about, thinking about this a little bit differently, that a single drug out of a therapeutic class may not be the ideal approach. And I think we've heard reference to market baskets. Does anybody want to maybe elaborate on how a setting that's more market basket focused or outcomes focused might look? Is that something anybody has any thoughts around that they might be able to share off the cuff, right? Okay.
We can jump on and just to, just to kind of reiterate, the purpose really here is to, solicit your feedback to the extent that, that can help sort of inform the board's decision making. So again, really looking for recommendations, suggestions on kind of the, what you would envision as not just sort of the challenge associated with her, which are very important, but also recommendations that you have that it would help the board in sort of that implementation. But next question we had, some of the survey responses had indicated that a UPL would have a negative impact on a patient's ability to afford their medications. To the extent that you agree with that, would you mind elaborating on what that those specific impacts might be? Again, thinking about sort of affordability at the member level specifically. Do we want to move on to the next kind of broader topic here, Linda?
Mhm.
And this is a kind of a segue from the last question, really, but specifically, thinking back to earlier in Linda's presentation, where we discussed the WAC changes, we had a little bit of a conversation about that earlier. Curious, how would you envision a UPL implemented at the manufacturer to wholesaler level in the supply chain? How would you envision that sort of that impacting your organization specifically?
Hey, it's Justin again. I think it's a difficult question to answer because as a health plan or payer who's paying the end provider, so the pharmacy or the provider office, physician, hospital, right, on drugs, that we have experience on, levels that those providers can purchase at, and our reimbursement's really on the final sale of the transaction. But what happens if somebody in that supply chain didn't follow UPL payment rules, and that provider at the end is saying, I can't purchase for what you want to reimburse me? And we get into situations then that are difficult of, I don't want to dispense said product because I'm upside down, and then we have a member stuck in the middle of access to care. I'm not an expert on what those individual wholesaler to provider. There's also variation based on the type of provider, right? Physician offices, hospitals, they have different purchasing trade classes. So that's difficult to see from our point of view, which is how are we paying for the final fulfillment of the pharmaceutical. But I can tell you that in today's world, that situation does come up where the end provider is saying, I can't dispense said product for the reimbursement rate, and now we have a member stuck in the middle, right? So the intent of a PDAB is to bring down the price, but with unclear levels of, what the markup and what the costs are, pre and post discount purchasing through wholesalers. The unintended consequence is going to be is I don't have a place to get the member this product, right? And then we've gone completely 180, which is maybe we have a more affordable environment for the drug, but I don't have a delivery system to get the member the medication they need. That's a big concern from a health plan payer perspective, and it happens from time to time today that those the terms and maybe it's a smaller independent pharmacy that doesn't have the same purchasing power as a large pharmacy, and they're saying I can't buy for that, so how am I supposed to sell for this? And we got a member stuck without access to drug.
So sort of building on that and thinking about member access, sort of delivery system implications. Are there other challenges that you would see similar to that for patient access? Is there concern that, UPL could prompt change in benefit design and strategies and, that those sorts of kind of more benefit oriented components? I think maybe our next question, Linda, we might be able to skip.
Yeah.
Maybe to kind of flip the current conversation on its ear a little bit. Some respondents to the survey actually indicated that they thought the UPL could create opportunities for a positive impact to patient access. If that's something that from your perspective you think is a potential, we'd be curious to hear what you think some of those positive impacts might be, or how the UPL could be structured in a way to ensure that it results in positive impacts to the member as opposed to those unintended consequences we've kind of talked about. All right. Moving on, something I think we've touched on, though not explicitly, sort of asked about over the course of the discussion is transparency. There were a number of respondents who mentioned transparency as being critical to a UPL program. Specific to this group and from your perspective, what does transparency mean to you? How would transparency be demonstrated in a UPL program?
I think it would start with publishing readily available information on what the UPL is on each product, how often it could potentially change, in order for all parties in the system to be aware, right? There's lots of nationally published pricing databases. I would assume that it would fall into those tables and those folds, right? Metaspan is a commonly used source of drug pricing, AWP, WAC, et cetera. There are federal upper limits that are available in those tables. Those sources are ultimately what most claims systems utilize. So I think a transparency would start with what's the intent with enough lead time to be able to accommodate in any system and environment. A list, if you will, on a website doesn't necessarily feed claim systems well. Right? CMS does lots on codes and pricing, and lots of private payers build, pricing models off of that. Drugs are generally like Metaspan and a couple of others, but that really powers the claims universe. So I would expect it to be somehow intertwined into those sources. Because the other part of this that gets a little complicated is there's parties, right, that don't have domicile in Oregon that are going to be providing product and care in Oregon, and they would need to have access to that as well to be fair and equitable.
Okay. So beyond certainly transparency and pricing and a publicly available source is hugely important, but are there other aspects of transparency that you think we would need to see, the collective we that is, that you would want to see within the marketplace? Are there expectations that you would have around not only how the price is published, but how the savings come through the system, work through the system, as an example? Are there other things that should be considered when modeling this transparency requirement or need? Perhaps other things you think the board should want to see, perhaps.
This is Elizabeth again. I would suggest perhaps have a work plan that allows corrections as lessons are learned, as a process for improvement.
Okay.
Any other comments on the transparency topic? Sort of building off of the really kind of an implementation comment about systems that you had made, Justin. Specific to your organization again, what other barriers, and I'm thinking sort of again like administrative complexities to implement from your perspective. What are the barriers, challenges, or risks do you see in terms of implementation? I mean, do you think that changes to formularies we talked a little bit about, as a result of the UPLs possibly prompting changes in provider referral patterns or prescription patterns, things like that, sort of unintended consequences or challenges associated with implementation that you might envision that we haven't already talked about?
I'm I think it's too early for me to know all the impacts. I mean, you mentioned a couple of them. Timing for said change is ultimately going to drive lots of different decisions. You know,
Mhm.
a lot of the decisions on drug coverage are generally done cyclically. I think I'd need to know a little bit more before we could really get an impact assessment. You know, there's system things, but there's process and policy and member communication and provider communication. And a lot of that's regulated in terms of like how much you need to be notifying before changes are made, right, for member and consumer experience.
Yep.
So I don't know enough yet of the details, but essentially we're, you know, the business, at least that we're in from an insured perspective, is highly regulated on how you can make changes, and this would be another variable into that process.
That's a great comment. Thoughts from others in terms of you know, implementation challenges, barriers, risks? Linda, thoughts on, do we move into, I know since we do have another session scheduled, I don't want to get too far down in the weeds in another
Mhm.
area, stop halfway through. So do we give folks a few minutes back and pick up in the next session discussing the methodologies?
Mhm. That's kind of what I was thinking too. For the next session, we do want to dive a little bit into methodologies and recommendations. And so it'll be an opportunity to think a little bit about what kind of data should be evaluated when calculating a UPL. You know, certainly the board has had a certain task before it to identify drugs to review, but the process of actually thinking about calculating or creating a UPL is actually a little further down the road. And certainly there are some things probably around, you know, legislation and rulemaking that have to happen before that occurs. But in thinking about that, what do those methodologies perhaps need to look like? What are the challenges that you see? What kind of data perhaps should be evaluated? And dive a little bit more into perhaps some of this medical necessity and therapeutic evaluations that we've mentioned earlier. And we'd like to take an opportunity at the next meeting as well to talk a little bit about recommendations. What other strategies do you think the PDAB might want to consider in addition to the UPL, and what would the potential positive impacts be? What would make it a potential either addition or alternative to the UPL, and what might some negative consequences be as well? So hopefully that helps guide thinking for the next week or so before we meet again.
I think it also just add to that too. I mean, you know, please, as you kind of think through this call after the fact, you know, if there are additional thoughts that you have, please feel free to send them direct to the email address listed there. Please feel free to bring them up when we get on the next call. Obviously, Linda kind of walked through our, you know, kind of primary discussion points for the next call, but we're certainly happy to kind of backtrack a bit if folks have other thoughts and want to dig a little bit deeper into any of the specific questions that we've asked today. So I guess with that, I want to thank everybody for their time, and we'll look forward to speaking with you again, hopefully very soon.
Thank you, everyone.
Thank you.